We all plugged in?
Yes, sir.
Thank you very much. Good morning, everybody. I appreciate you coming out this early on such a cold day. I lived in Chicago for about 15 years. I know what cold is. I tried to escape it, but it seems to have found me. Today we're going to talk a little bit about advanced imaging. So I'm going to try to gloss over the issues of echo and nuclear to the more advanced imaging platforms that we have and that are currently being performed here at ECU and Vidant. Of course, I have no disclosures yet. Okay. For most of us, we're sort of familiar with the basic cardiac imaging devices, echocardiography, nuclear medicine, nuclear cardiology, cardiac cath, coronary angiography. And we'll talk a bit about cardiac CT and cardiac MRI. Cardiac PET, although it's a great procedure, has been fraught with a lot of troubles with the government. At first, FDA took away rubidium. Apparently there were some problems with the cyclotrons generating rubidium. But more recently, the issues have been related to reimbursement. Okay. I guess the first question that any physician taking care of patients needs to answer is, what do I want my cardiac imaging to give me? Do I want structure? Do I want function? Do I want to know whether they're ischemic? Do I have a problem with understanding their anatomy, not only coronary but cardiac anatomy? This is particularly important in patients who have congenital heart disease or adult congenital heart disease. And lastly, but really growing leaps and bounds, especially at this institution, is the use of cardiac MRI to assess myocardial viability. Is the muscle alive or is it dead? And this slide, although it looks very complex, really is nothing more than a comparison of our tests, both non-invasive and invasive, and relative to the degree of stenosis that the test can identify. And of course, unfortunately, stress ECG, which is probably the oldest of all non-invasive testing, has an ability to pick up stenoses that are about 75%. When you go to nuclear or stress echo, they're both basically about the same. They could pick up stenoses at about 65%. When we move on to the to cardiac CT, and I use and I put EBCT, electron beam cardiac CT, just from a historical perspective, since nobody uses that anymore. I don't think they even make the machines anymore. And MR stress perfusion, you can see that the degree of stenosis that can be picked up, or in MR stress terms, the degree of stenosis leading to perfusion abnormalities can be as low as 35%. Cardiac cath, or coronary angiography, has the ability to pick up even the most subtle abnormalities, things that we call lumpy, bumpy coronary arteries. This slide is very old. It's from Lance Gould, who is sort of the father of modern-day coronary physiology. And what this slide shows, very simply, is that this is stress perfusion of the coronary, and this is resting blood flow. So you can see that when you become hyperemic, that is to say, when you increase the blood flow stays normal until you're at about 80% stenosis. And this is where, from this paper, we decided that anything over 70% would be considered significant. And the reason for that is you can see that resting blood flow begins to diminish as the stenosis gets worse. Okay? I threw this slide in maybe a little bit out of order, but I wanted to give you a heads up about it. This is very recent literature data that looked at the amount of radiation exposure from all of our cardiac imaging techniques. And you can see that a chest X-ray gives you only about 1/10 of a millisievert, A cath gives you 7. A nuclear stress gives you 11. A CTA in good hands gives you 12. And thallium, because of its longer half-life, so it's sticking around a lot longer, actually gives you 24 millisieverts. So you calculate how many chest X-rays a patient is exposed to when they get a thallium stress test. Thallium these days is only used for the 2-day studies. Those are usually performed on patients who are obese. And the isotope, because the isotope lasts a long time, it gets into the myocardium and can be imaged. But we very rarely use thallium per se. MIBI is what we use right now. It's a technetium isotope, and the isotope has a clearance that allows only about an exposure of 11 millisieverts. Millisieverts is the new term. It replaces REM, so you'll hear a lot about that. This is a typical coronary artery. In many of our patients, I'd say it's unfortunately too typical, and you can see the stenosis in the mid-segment. So the question I go back to is, what are you looking for? Patient comes to the emergency department with chest pain. Are you looking to know, do they have coronary artery disease? I know they have coronary artery disease, but is this disease now worsening to the form of an acute coronary syndrome or STEMI? Or are they short of breath and I don't know whether or not it's coming from their lungs or their hearts? And these are the kinds of questions that we are often called to answer. And hopefully I'll try to give you some answers today. Well, a procedure that's been around now for a good almost 20 years. I was doing EBCT research when I was a fellow in Chicago back in the mid-80s, And what cardiac CT is, everyone has seen a CT scanner? Yes? Yes? Okay. We're using a different form of exposure to the heart. The two things that we do differently with a cardiac CT is that instead of just imaging in circles, okay, where patient is in the table, image, move the patient, image again, move the patient, we use what's called a spiral configuration. So patient's in the table, the gantry is that big round thing, and that gantry is spinning at very, very high rates. And the table is slowly moving through the scanner. And what that allows us to have is a spiral kind of image. Now, it images usually twice or 4 times, so it gets all 4 quadrants, if you will, of the circle. And what that allows us to do is, by computer, put them all together, and we're able to create a picture. Well, the question that people say is, okay, your CT scan is a nice thing, it makes pretty pictures, but how accurate is it? Well, the sensitivity and specificity overall is about 75 to 90% respectively. And I have to argue that that's pretty damn good, considering our other tools. The major benefit of cardiac CT is that it has excellent negative predictive value. And for you young students, you're going to learn what is negative predictive value. That is the benefit of the test or the ability of the test to show what's not there. So if there's no coronary disease, there really isn't any coronary disease. And the negative predictive value of a cardiac CT is somewhere about 99 to 100%. And this slide, I just want to show you, I don't know if you could see it, it may pop back. This is a slice of the heart. This is the left atrium. This is the aorta. This is part of the left ventricle. And this structure right here is the coronary artery. And I'll try to move it over to the next one. And you can see the left coronary is rather well visualized. But unfortunately, as you can see, the connection between the aorta and the left coronary is kind of skimpy. So that suggests left main coronary disease. But you could see these vessels extremely well and actually make a diagnosis. You might see pictures like this in Time magazine. I believe they've already published. We don't really use this technique. It's called video rendering. So we make pretty pictures that everybody could see, but it doesn't really help us. Just to reiterate, using a two-source CT, remember the gantry is that round thing. Normally they have single source, so they have one X-ray head that's spinning around. And here, Siemens has created a dual source scanner where there are two. So the acquisition time of taking the test is much, much lower. Sensitivity using the dual source and specificity were incredibly high. And of course, the negative predictive value followed along very closely. Here is a 3D rendering, just so you could see the quality of the study. This is the left anterior descending artery, high-grade stenosis, coronary angiography, same LAD, showing the same high-grade stenosis. You can see the accuracy, you can see that small little septal perforator branch, which is right there. So what you see is what you get, and if the patient can hold his or her breath for about 10 seconds, we get some really good pictures. I'll talk a little bit about calcification, but I really just want to move through a lot of these slides. These are the coronary arteries. This is the aorta. This is the left anterior descending, the diagonal, and a second diagonal. And in here, the AV groove, the atrioventricular groove, is the circumflex. This is the right coronary. This is a non-contrast picture. So all we did was put the patient in a scanner and gate their heart to the machine, which means it only takes images during diastole. And you could see how much calcium there is in these coronaries. Certainly not the kind of coronaries that an interventionalist would want to work on. You'd hear glass breaking throughout the cath lab if you tried to stretch those, and also a lot more complications. But coronary artery calcification has become the new mantra for pre-symptomatic coronary artery disease. This is just, these are just two pictures looking at what cardiac CT can do. This is a coronary artery, and with one of our techniques in the software is we can literally take one of these coronaries that are all curly-cued and we could straighten it out. And here you could see a stent placed, and right in the middle you can see some in-stent restenosis. This, if any of you has not been to the operating room to see bypasses placed, this is what the coronary and bypasses look like attached to the ascending aorta and grafted distally. This one is to the right coronary. This one is probably posterior to the obtuse margin. And these images, of course, because they're acquired in 3 dimensions, we can rotate them to any degree we like. An often rare cause of chest pain is an aneurysm of a bypass graft. I guess very much a venous varicosity, if you will. And this, of course, changes the flow dynamics. Clot builds here, small little pieces break off and go distally. And here you can see that the graft is completely occluded distally. This one is just for your information. This is a CT in a patient who has a left ventricular assist device. So you can see this is externalized pump. The blood is removed from the right side of the heart excuse me, the blood is removed from the right side of the heart and pumped into the aorta. Okay. Well, we could also use coronary cardiac CT for other reasons. Patient has atrial fibrillation, evidence possibly of esophageal varices where you don't feel very comfortable passing a TEE probe and you can't see the atrial appendage on transthoracic echo. Here you can see with a very, very high degree of accuracy a left atrial appendage thrombus that's just been sitting. Okay, what's the problem with cardiac CT? It sounds like a great technique. We should be doing it on everybody. Everybody should sign up when we leave here. Radiation exposure used to be a worry. It's not as much of a worry now as then because of all of the techniques that we use to limit radiation. I don't know if it really has hit America like it's hitting Europe, but physicians are becoming more and more aware of the dangers of radiation, and they're doing everything in their power to minimize exposure. In the early days of cardiac CT, remember I told you thallium had 24 millisieverts of radiation exposure. Cardiac CT was probably about 20 millisieverts. But now we realize that we can image a lot faster, and we can image in a way where we're only turning the tube on only during certain parts of the cardiac cycle. And remember, we're only really imaging about 5 heartbeats because the acquisition time for this device is only about 10 seconds. So if you can figure out a way of turning the machine off during systole, because we really don't care, we're not imaging during systole, we're mostly concerned about diastole. So if you could turn the machine off during systole, you're really reducing the exposure to radiation by a phenomenal amount. There's nothing we can do about contrast, and there's nothing we can do about iodine in the contrast. But with the newer machines, because they're able to digitize the images, you can see a lot more with a lot less contrast. Some patients, well, you may think 10-second breath hold is easy, but how many of you have asked patients to hold their breath, and then you just see their abdomen still moving? Okay, so 10 seconds may seem like an eternity to some patients. If the patient moves during the scan, you lose the pictures. The presence of calcium, although that image that we showed earlier, is probably a reason not to proceed with the test. After you do a calcium score, which is usually the first thing we do, if the calcium scores are, 1,000, normal should be 0, and you can't see under the calcium, you're really not going to be able to identify or delineate the underlying plaque. This is probably the most important thing that we can influence is the heart rate. Remember, the slower the heart rate, the longer the diastole. So, and we're imaging during diastole, so you want to slow the heartbeat down. Don't be afraid of a little bit of beta blocker. If the patient has an allergy or has respiratory problems with beta blockers, you can certainly use cardizem. All you want to do is get their heart rates below 70, preferably around 60. And I have a slide down the road that'll show you a little bit of the difference between the imaging quality. Okay, so as we talked about earlier, perfusion studies give you about 15 or 16 millisievert exposure. Cats are about 7. Cardiac CT without contrast, just looking for the coronary calcium, is only 2. And for cardiac CT, doing the whole kit and caboodle, it's about 14 millisieverts. So although the EP studies tend to take hours and hours, it's not that they're getting a lot of X-ray exposure. Well, several studies have been published in the last few years looking at the prognostic value. Since we're all interested in evidence-based medicine, we have to prove that our technologies do the trick and that will actually save lives ultimately. The second of two trials was called the ROMICAT, and I'm not going to get into what it means. Basically, it was a 2-year this was a 2-year outcome study. I'll go back to the original in a second. A 2-year outcome study predicting MACE, major adverse cardiac events, in patients who came to the ED with acute chest pain. The ROMICAT study was designed to determine the usefulness of cardiac CT in patients with acute chest pain. And the results showed, this is ROMICAT, that of the 300 and some odd patients, ACS was present in about 8% of patients who come in with chest pain. So you're dealing with eliminating 92% of your patients. With cardiac CT, 50% of these patients had no coronary artery disease. So you're talking about a very large number of patients that will ultimately be admitted, have a nuclear test, have an exercise test, have multiple troponins drawn, and cost them a lot of money, and the insurance companies as well, and lo and behold, half of them are not going to have any coronary disease. 30% had non-obstructive disease, lumpy, bumpy stuff. Okay? Great patient population to really try to intervene on. Aspirin, statins, etc. 19% had an inconclusive study or did have a positive test. So looking at 368 patients, we find that the incidence of ACS was only 8%. And of the 368 patients, only half of them had some form of coronary disease. So the 2-year follow-up study, which was performed by the same centers, looked at, nonetheless, the end of the 2-year follow-up, there were only 6.8% of the patients who experienced MACE. Okay? 12 had no events, no cardiac deaths, 12 had MIs, and 23 revascularizations. So the cumulative probability of MACE increased across the strata of cardiac CT. So if they had no disease, they had no events. Non-obstructive disease, very low rates of events. Obstructive disease, the highest. And across all of the CT data that they collected was not only whether they had coronary disease, but did they have regional wall motion abnormalities. That seemed to have a rather predictive sign as well. Here you can see, this is just the log rank data, that in those patients who were submitted or subjected to cardiac CT, okay, by 52 weeks the curves start to separate, and those that had no disease or non-obstructive disease, the MACE rate was extremely low. But those with obstructive disease, which all of our previous studies have shown, will develop MACE that climbs by about 104 weeks. In this slide, they broke it down looking at whether they had coronary disease and regional wall motion. And what you can see here in red, if they had both stenosis and regional wall motion abnormalities, they were very likely to have an event. If they had neither coronary disease nor regional wall motion abnormalities, by 104 weeks, they were pretty much clear. Okay, we talked about that. Okay. This slide I just put in to interest you or future researchers. Not only is the technology going toward improving imaging as well as reducing radiation, but we are now able to measure fractional flow reserve by cardiac CT. So this really offers a great advantage in that you're not only looking at the stenosis, but you're actually looking at the flow through the stenosis, very much like what we do in the cardiac cath lab. And basically what we do in the cath lab is we see a stenosis, we pass a wire into the artery proximal to the stenosis, and we measure the pressures there. And then we advance this wire well down, there it is right here, and then we give the patient adenosine. And adenosine will vasodilate. Now, the whole theory about coronary disease and vasodilatation is very simple. As this lesion approaches critical degree of stenosis, the flow, the resting flow in the artery drops. The artery responds by dilating itself. So when you give adenosine, you may have dilatation of the circumflex artery, of the right coronary artery, but you're not going to see very much dilatation in the LAD. So when you measure the delta, the flow at rest and then the flow following adenosine, that delta is very low. And that's what we call FFR. Well, instead of sticking a 14 thousandths wire in a patient's artery, subjecting them to contrast for this part of the study and potentially injuring their coronaries, we could do this by cardiac CT now. And you'll see that over the next 5 years or so, this is going to become a pretty much standard. Okay. Well, let's talk about cardiac MR for a minute. Cardiac MR, this is the near and dear to my heart. It allows you to do a lot of things for a relatively short amount of time. You can assess the anatomy, look at the cardiac structure, especially important in patients with congenital heart disease. You can assess the pericardium, especially in patients who have constrictive pericarditis. You can certainly look at the function. We're looking at valve function as the next frontier, but you can certainly look at the flow in vessels. Myocardial ischemia is exquisitely visualized by cardiac MR, and in myocardial viability, MR has become the gold standard for assessment of myocardial viability. And the advantage of all of this is that no radiation, none at all. Okay. So when we're looking at the anatomical assessment, we look for all various different things, of course, whether the ventricle is normal, dysfunction, hypertrophic conditions, congenital abnormalities. Probably the most common that we see is a PFO or an ASD. Luckily, cardiac tumors are relatively rare, but we are fortunate enough to have this device to see that. And the nice thing about MR is that because it's all computer driven, you can basically tell the computer exactly what image you want. Whether you want to look at the bottom of the heart, the side of the heart, you want to cross through the aorta and the right atrium to see if there's any shunting, etc. MR can do that very, very easily. Okay. This is the quality of a typical MR, and you can see things probably that you can't see with other technologies. We have the ability to measure not only the dimensions of the aorta, for example, but also the flow. We can look at the tricuspid valve, which is right here, the aortic valve. You can see the papillary muscles are extremely well visualized, pulmonary artery. So it's really giving you a very, very nice quality of the anatomy. Let's see if this works. Nope. Let's go back. Nope. Oh, I'm sorry that I don't have my... I hate PowerPoint for this reason. Well, these movies were supposed to be movies, not just single pictures, and I apologize for that. But what you see in these images, and basically you'll say, why the heck did he put three pictures of the same three pictures of the same thing on the slide? Actually, they're not the same. We've sliced the ventricle 3 times, and you can see the thickness of the papillary muscles is a little bit different. Here, it's kind of long. Beautiful image of the mitral valve. And I guess this is, okay. Well, so that was supposed to show structure. Myocarditis, again, MR is an extremely useful tool for myocarditis. And in this image, you could see myocardial edema, which is this darkened area right here. Okay. And then, as the course of myocarditis continues, you can see how it becomes dilated and obviously very deformed. So we have the ability almost to sort of date myocarditis, if you will. All right. Now this one works. This is myocardial perfusion. So basically what we're doing here is we are imaging the same part of the cardiac cycle in multiple beats. So you're not seeing systole and diastole. And we then inject gadolinium. And focus on the fact that you can see at first pass, which means the first thing you're going to see is on the right, then on the left, and then you're going to see it in the myocardium. Okay? And this is the 2-chamber view, and this is the base of the heart, and there's the apex of the heart. Okay. I'm not as klutzy with my stuff. I apologize. Play. Again, I apologize for the poor quality of my, okay. Here in this image, and it's really interesting, I don't know why some did capture and some didn't. Here you see this is a 4-chamber view of the heart. Here is the interventricular septum, the mitral valve, okay? And you can see how the septum and the apex are thickening. But if you look here, you see that the lateral wall is thin and akinetic. Even though it looks like it's moving, it's really not moving at all. So identifying myocardial infarction is another great trick. And here, again, coronary angiography showed a totally occluded right coronary before the vessel was reopened. But again, in using a different kind of sequence, you can see this very bright area. Do you see that? This very bright area is reperfusion injury. So it really allows you to quantify myocardial infarct size. Okay. Now, luckily, these are not AVIs, so you can see. If we give you contrast and we wait 12 minutes, the contrast is going to seep into myocardium and then get washed out very quickly. If, however, you've had an MI and we give you contrast, the gadolinium is going to sit there because there's a lot more extracellular space or interstitial space. So you can see here that the gadolinium gets caught in the myocardial wall. In this particular picture, it's a septum. In this particular picture, it's the apex. So being able to say, well, you know, that EKG showed an infarct, and the echo shows the wall motion is not working. Let's go ahead and do a viability study and see if it's going to pay to revascularize this vessel. Well, this is all about delayed enhancement, probably more than what you need to know. But the point I was making with this slide was the following. We can separate ischemic from non-ischemic pathologies simply by looking at where this gadolinium deposits itself. In this particular case, obviously you can see there's a subendocardial infarction with the black myocardium still behind it. In this image, you see that the wall is transmurally infarcted. In those patients with non-ischemic, all of these findings of delayed enhancement lend themselves to poor prognosis. In this particular case, if someone has dilated cardiomyopathy or burned out myocarditis, you find the delayed enhancement in different places. In patients with hypertrophic myopathy, and you would think these patients have great ejection fractions, their arteries are so big I can park my car in them, you're going to find that there are areas within the myocardium that have infarcted, probably because of an imbalance between supply and demand. In these patients with HOCM, carries a very, very concerning prognosis. We can also look for infiltrative disease, such as sarcoidosis, myocarditis, Anderson-Fabry, amyloid, Chagas, you name it. Okay? And what we find with these is that the hyper-enhancement, that's what the AG stands for instead of delayed, tends to be on the epicardial surface. In these patients, you tend to see large areas of subendocardial ischemia, especially in amyloid and some connective tissue disorders. So here's another picture of delayed enhancement of the inferior wall. This is a transmural infarction, which if we revascularize that, likelihood of any substantial improvement in LV function would be minimal. In fact, surgeons won't bypass those. Okay. A lot of delayed enhancement. These are real pictures instead of those images that you saw earlier of what an ischemic cardiomyopathy looks like. Here it is subendocardial and a infralateral infarct. Here in myocarditis, you can see that the subendocardium is preserved. And here in dilated cardiomyopathies, this is where you'll see the delays. Now, just a point. You may wonder, when you call cardiology and you have a patient with a heart failure and their troponins are up, and you're looking and figuring out, do they have coronary disease as well? Okay, chances are they have this pathology going on. Okay, that the mesocardium, if you will, becomes ischemic and infarcts for some unknown reason, or whether the area is just dying via apoptosis. So this, I wonder, yay, it works. Okay. So this is a rather different kind of heart failure. Of course, this is the typical dilated cardiomyopathy type, and unfortunately, or fortunately, I guess, it affects just the left ventricle. You could also see a little bit of regurgitant flow there. Tumors. I'm afraid that picture isn't going to work. This is actually, you would think, well, it's in the left ventricle. Actually, this is a left atrial myxoma that we picked up for somebody. Actually, it was a volunteer who was coming in. Okay. All right. Because these slides are not doing what I want. Oh, yes. Nice picture of a bicuspid aortic valve right there. Here is a image of aortic stenosis. But you can see that the jet, which is in white, is right there. And so overall, cardiac MR is now considered the gold standard for assessing myocardial morphology and function. It provides unparalleled utility in the identification of congenital heart disease, and that may be one of the reasons why you guys can't get your studies done quickly, because when they do cardiac on children, you know, they have to sedate them and you need anesthesia, etc., and those usually take about 4 hours. And myocardial perfusion studies can identify areas of subendocardial ischemia where other techniques, especially nuclear, are incapable of identifying these abnormalities. One of the most important clinical benefits of cardiac MRI is the ability to evaluate myocardial viability, thereby assisting strategies for the management of ischemic disease. And the other benefit is, of course, there is no ionizing radiation. So my take-home message for MR is it can assist you in the management of ischemic disease as well as in terms of identifying LV function and myocardial viability. And I thank you. I'll be glad to take any questions that you might have. Yes, sir.
Thank you for the excellent review, Dr. Katsuri. You mentioned about fractional flow reserve in cardiac CT. Is there any comparison between CAT and cardiac CT?
The coronary flow reserve studies that are currently being performed and the pilot studies showed very, very good correlation. Very good. In fact, my group at the University of Florida back in 2007, we published a paper looking at coronary flow reserve and perfusion abnormalities in MR. So we found that there was a very, very high correlation there. So it wasn't sort of what word do I want to use? Just luck. But if you see a perfusion abnormality on a cardiac MR, you know that the FFR, if you were to go ahead and use a cath and a wire FFR, your results would be identical or very, very close. Anyone else? Yes, sir.
Thank you for the talk. I had a quick question about what you envision in the future. Do you envision that this technology could also predict the tendency of a plaque rupture?
Well, that's an excellent question, and I can tell you that a lot of millions of dollars are currently being spent in grants to prove or disprove that. As the technology improves, you have to remember it was only about 15 years ago that we were creating 4-slice machines. So we had 4 rows of detectors. Okay, we now have 64. If this were Duke or a place that had a lot of money, we would have what large centers have, 320 slots. So what the 320 allows you to do, and when we talk about the number, we're just talking about expanding the width of your imaging plane. So you can get the whole heart in one breath hold, in one heartbeat. Then the issue with CT has always been spatial resolution. Okay? How small can the pixel be so that you can identify a change from gray to black or white? That's coming. That's what the whole concept of the dual source was all about. And dual source is a great technology, but it just didn't make it. But I have to say, watching the past 10 years, the technology for this, just the progress in technology for these imaging devices, coronary angiography, I guarantee, will be a thing of the past for the vast majority of patients. In fact, I just saw a webinar last week about using MR to pass swans. So we are very much aware of radiation. We can lower the radiation not only by shortening our image time, but by using other technologies. Will it tell us plaque? That's, I'd say maybe that's a little bit further down the road, because what you're looking at is if the typical coronary artery is 3 millimeters in diameter median, and the wall is usually less than a millimeter in thickness, you now have to have a device that's going to be able to image probably 10 times smaller than that 1 millimeter, because you're going to have to be able to differentiate the layers. And at that point, we may be using something called MRI spectroscopy, which we can't use now because the exams take 2 hours to look at one coronary. But who knows what's around the corner. So I think primary care is so important, especially internists and people who are seeing these kinds of patients, is that you now have this incredible armamentarium of what tests to order. You don't need to call a cardiologist to order a cardiac MRI. You don't need a cardiologist to order a cardiac CT. And why we're not using CT here in the emergency room to rule out half these patients who come in with chest pain and they have normal nukes and they have normal this. They're spending money, and we're not getting any closer to using that technology. Hope that answered the question. Yes, sir.
So in a follow-up to what you just said, are these new technologies, which seem like they cost a lot of money, you're implying that they could perhaps save money or not?
They do. The CT stat trial, which I did not show you today, was the first study to show equivalence in the cost of doing a cardiac CT compared to admitting a patient, doing a nuclear stress test, keeping them overnight, and sending them home. It was about $4,000 each, whatever they calculated. Think of it this way. The CMS got very smart about cardiac CT and cardiac MRI very early on. They vowed never to make the same mistake that they did with nuclear cardiology. If you look at nuclear card reimbursements, it's through the roof and has been for many years. When they came out and said, okay, we're going to let you use CT and MR, the physician reimbursement for a full study MRI is about $275. The hospital, of course, gets the technical fee. So it probably will be anywhere between $800 and $1,200 for a cardiac MRI. A CT in other markets, a calcium score costs you $50. So I guess, and if a calcium score, if I walked in and said, I have hypertension, hyperlipidemia, my male relatives all dropped dead before the age of 50, I want a CT. Is that going to save me? Is that going to save money? I guess you just have to, do the actuarial studies, but it would seem to me that yes, you are saving money. And with the high negative predictive value of cardiac CT, where if you don't see anything, you don't see anything, those patients can go home. So I guess all in all, those trials, those very large multi-center trials are currently in process. But I'll bet you we're going to find that a hospital would be foolish not to be using cardiac CT. especially in this kind of population. Many are indigent, one test, no admission, etc. Because they're not going to get any money out of it. Yes, sir.
We've had people who found with lipids were not tolerating statins.
Uh-huh.
Some doctor Mob had $50 was negative, but I don't even worry about the statins. I think it makes sense to me.
Well,
You got zero scoring, calcium score is
yeah.
zero. Maybe you don't have to worry about anything else like that.
I tend to agree. I think aspirin is probably the drug of choice in those patients, but it would be nice to know whether you have lumpy, bumpy coronary disease with all your risk factors, or whether you have, clean coronaries. Now, I say this: the calcium score is only going to look at calcium, and that is very useful in a more elderly group of patients, say 45 to 70 years old. Once they get over 70, everybody has calcium in their coronaries, and it's very hard to look under it. I wouldn't expect to find, I wouldn't even do a calcium score on a 25-year-old who came in with very convincing symptoms, but no EKG changes, because I don't expect to find a calcified plaque at that age. I expect to find a soft plaque. So, as a preventative strategy, I think this will find its greatest utility in that age group with very prominent risk factors or in diabetics. And I think that is probably where we should be going with this. In fact, in 2010, AHA came out with a position paper that looked at what non-invasive tests should we use on asymptomatic patients who have significant risk factors. And they went through all the tests. Should they get ABIs? Should they get this? And the only one they mentioned for cardiac CT was in the diabetic population. And we know that that population is growing. And so it might be a good idea to start thinking about the use of this device in those patients. One more thing. In cardiac MR, because the resolution of the spatial resolution, the pixel size, is so small, we have the ability to look for microvascular changes. So you may see a nice ventricle, and it's got all the white gadolinium in the ventricle, but right around the edge, in the subendocardial area, there's a nice ring of ischemia that you'd never see by any other test. Okay? Interestingly, those patients with syndrome X have similar findings, but they looked at these patients over years, and they found that their mortality was no different than anyone else, but their quality of life was in the dirt. But a diabetic who doesn't have epicardial disease, but gets short of breath when they're walking, and they don't have any lung disease, an MRI might be useful to see do they have microvascular changes, and then you can obviously direct your therapist toward that. Any other questions? Thank you. I apologize for some of these slides.
Every time I listen to you talk, my interest in imaging goes.
Well, I'll tell you. Think about it. Think about those people who are in all of those interventional fellowships. And I keep telling the interventional fellows, you guys have to learn cardiac CT.
Yeah. So do you think imaging will be more and more coming in the curriculum for general cardiologists?
Here? Oh, absolutely.
Or in general?
Oh, yes. In fact, I sit on a committee looking at that specifically, and for ECU, I've been commissioned to develop a curriculum, and so I'm giving the fellows lectures. But the curriculum is already underway, and we just got another another imaging specialist from Holland.
Oh.
He's Romanian, but he's actually worked in Holland, so he hopefully will be developing our MR database. So you're going to see more coming out of this lab, and they're building a 3T. They're going to put in a 3T, 3 Tesla magnet. The only way you're really going to be impressed with this technology is by ordering the test and looking at the images. They're really impressive. I don't know why it won't let me take my thing back.
Looking forward to starting in July and learning more.
Oh, we've got the whip all nice and lubricated. Work!
My dad couldn't come, but he wanted me to tell you what it is.
Oh, yes, I know this guy.
But he said he had to do a procedure.
That's okay. I hope that you'll pass it on that I did an okay job.
Oh, yeah. That's
Okay.
great.
Thank you.
Yeah.
Appreciate it. Maybe we'll get you away from surgery one of these years. Stay warm.
Our friends being have been sent by my seniors to find out when you would like to round today.
See, there's no rest for the weary. Well, are you guys ready?
Not quite. I think we still have to see a couple more.
Who's rounding with us?
Sandeep?
Okay, so what does Sandeep say? Thank you.
Yes, sir.
Pissed off. I made 3 copies, 2 jump drives and this, figuring my images would work.
Right.
It throws you, you know. Is this one of your seniors?
This is one of them.
Well, at least he showed up. Yeah, I know. You were so loud snoring, I was almost going to throw something at you. Thanks, guys.
Thanks, sir.
Thank you. I can't get it to stop.
It's not stopping.
No.
Huh. What is this?
I have no idea.
That's weird.
Yeah.
I haven't seen that before.
Yeah, it is not letting me stop it.
That is weird.
Mm-hmm.
Don't want to lose this talk either. It's
No, I
not
don't.
good talk. So it's not doing anything when it does stop, you said?
Nope.
How about try doing save? So it's stopped basically.
Yeah, it's now just stuck.
Jeez. How about just do control?
That's what we're gonna have to do.
And then maybe try stopping something else first. See if that fixes. We might end up losing it. Jeez.
Nope. What I can do is we'll do this. Usually something like that gets it.